Hi, everyone. Thank you so much for joining us. It's our weekly Wednesday seminar for the Center for Healthcare Policy and Research. It's also our public health one unit seminar in the Department of Public Health Sciences, and also some people here to get some CME credit. But we are really excited to have today a talk that's sort of at the intersection of two areas that we work in at CHPR, both the clinical space, but also a policy space. And so we're really fortunate to have Dr. Erik Tseregounis here today, who's an adjunct assistant professor here in the Division of General Internal Medicine. Um, Erik was not a lifer of Davis, but a longtime Davis uh, um, alum, plus now faculty member, so got his PhD in epi here at Davis and was a postdoc in substance use in internal medicine for a number of years, and now is joined us as faculty in our division. And his talk for today is really going to be about evaluating and expanding treatment for tobacco use among people with substance use disorder in Northern California. So thank you so much for being here, Erik, and please take it away.
Right. Thank you so much. Yeah, I wouldn't quite call it a lifer. I haven't
Not a
didn't come to
labor.
yeah, I didn't come to California until I was 30, but I have been in the area for over 10 years now, and have been very fortunate to get to work with a lot of people at the Center for Healthcare Policy and Research and here at the division I'm in right now in internal medicine. And what I'm going to talk about today is really the culmination of a lot of that work. And a narrowed focus towards the intersection of tobacco, and treating other substance use disorders, not only in the area, but broadly. My work currently is more focused in sort of the Northern California region. So that's what we will go into here today. I don't have any disclosures, a conflict of interest. And so just a little bit of a summary to orient what this talk is going to be about. I'm going to introduce some background as to why this is an issue that concerns me and many of my colleagues, and talk about two treatment settings that we are doing work in currently: inpatient in hospital and outpatient, specifically in substance use treatment facilities. So, what is substance use disorder? It's a complex mental health condition that involves problematic patterns of substance use, uh, colloquially called addiction, but addiction only represents the most extreme forms of substance use disorder. So there really is a range of disease, and this is treatable through counseling and pharmacotherapy, and it's unfortunately quite common with just south of 20% of the US population being diagnosed with substance use disorder in 2021. So that being said, what are substances exactly? Um, and this is a figure from SAMHSA from a couple of years ago, which sort of lists the main substances that are included in this large package called SUD, substance use disorder. And notice how tobacco is not included. So you've got pretty much everything here. Alcohol is the most common, quote unquote drug, which mostly prescription opioids, and then you have illicit medication or illicit drugs included here as well. But it's primarily alcohol and opioid use disorders that are part of what we call substance use disorder. So why am I interested in substance use disorder and tobacco? And it's because there is a huge disparity in terms of the prevalence of tobacco use among people who have a substance use disorder and the general population. So, depending on the treatment setting, you have a 6 to 8 fold difference in the prevalence. And people with a substance use disorder are very likely to actually be current tobacco users as well. And naturally, there is a lot of morbidity and mortality related to that usage. And so, people think of the main harms of SUD being related to overdose. In reality, it's related to their tobacco use. So you have double the mortality rates related to tobacco related disease than, or excuse me, double mortality rates in this population in terms of tobacco related disease than the general population. But you also have tobacco related disease as the most common form of death in this population. So it's an issue that is greatly disproportionate to the rest of the state in terms of this population's burden with tobacco use and related disease, but unfortunately does not get enough attention. So why is the prevalence so high? Um, it's a very complex question to answer, but generally there are biological reasons for why people tend to use tobacco when they're using other substances. The nicotine in tobacco can enhance the positive effects of the other drugs. The In treatment, people may often go into treatment not being current smokers and then come out of it being smokers because smoking is often used as a substitution for the other substances. It can also be used to potentially reduce withdrawal symptoms when people are coming off these other substances. There's also what's been identified as the nicotine pain paradox, where if you're someone with chronic pain, oftentimes in the short term, nicotine will reduce those levels of pain, but in the long term, it would actually cause you to have more pain due to other physical comorbidities. So it's this vicious cycle of in the short term, you develop this smoking habit because it's helping you manage your pain, but in the long term, it's exposing you to more pain. So you're having to take more pain medications to cope with that. And then that feeds into this cycle of more tobacco use, more pain analgesia use, and so on. Historically, unfortunately, tobacco has been ignored in substance use disorder treatment settings. And the literature has gone into this extensively. It's primarily identified organizational barriers. So these organizational barriers can be at the facility level. So the managers, managing agencies of these treatment facilities, they tend to view tobacco as being separate, as not a part of behavioral health, let alone of substance use disorder treatment. And within the facilities themselves, providers are often put at odds with tobacco. And this can be due to sort of traditional views on whether tobacco can be co-treated with that individual's other substance use. Um, Oftentimes, it's seen as being antagonistic when a lot of the literature done in the past decade or so has shown that to not be the case. There's still this traditional view of treating tobacco as taking away from treating the other substances. And it's also seen potentially as a substitute. I already mentioned this briefly, but oftentimes the providers in these facilities, so the staff, are smokers themselves. And so they view smoking as less harmful than the other substance use. And if someone is having issues withdrawing or having issues with elevated anxiety, they rely on the nicotine from the tobacco, from the cigarettes primarily, to help that individual cope and help them in their recovery. And so this is leading to this unfortunate pattern where you'll have more people coming out of recovery with current smoking than going in. There's Despite the fact that there isn't a lot of co-treatment going on in these facilities, there is a lot of evidence identifying the benefits of co-treatment. The patients are really interested in quitting, and they've identified that. So there was this initial idea that, oh, patients don't want to quit smoking. They're not here to quit smoking. The reality is the opposite of that. Patients are interested in quitting smoking. They just don't feel like they can. And so the work that needs to happen is to help them understand that the recovery is just from smoking is something that they can do at the same time as their recovery from these other substances that they're being treated for. The staff themselves often are smokers. They want to quit and they want to help their patients quit. And so there's this untapped potential in a lot of ways in these facilities where patients and staff want to quit, but there are these barriers that exist due to sort of cultural inertia, so to speak, that exists that prevents the introduction of treatment into these settings. The treatment approaches for tobacco are very similarly aligned with the treatment approaches for other substances. So, for example, there is medication assisted treatment for nicotine. So you can get nicotine replacement therapy. There's also the the behavioral health approach that is applied to treating other substances in terms of screening, intervention, and referrals to treatment, it also exists in tobacco treatment as well. So it is not like you're bringing in a completely new treatment paradigm. These work very well together due to the underlying framework being so similar. So my research is really focused on evaluating and improving access to tobacco treatment for people with substance use disorder. And in my work, I've really gone about this at looking at it from two different approaches. The inpatient side, so patients that are admitted to hospital, ensuring that they have tobacco treatment there. Patients cannot smoke in a hospital, they can't smoke on hospital grounds. So if they are admitted, and they will often go through withdrawal. And so it's important to manage that withdrawal. And also, if they're interested in cessation, support them in that cessation journey. And then outpatient, once the patient leaves the hospital, are they going to be offered the same levels of treatment? Are they going to have access to the same levels of treatment? And so those are the questions that we were really focused on answering. So just to visualize what I had mentioned, in terms of the continuity of care for tobacco treatment, you'll have a person likely with substance use disorder presenting at the ED. They might be admitted to hospital. They have their inpatient hospital stay. They'll get discharged potentially with medication or treatment orders to an outpatient substance use disorder facility. And in terms of non-tobacco, this has been greatly improved in this area through the CA Bridge program. We have that at our hospital, so we have bridging to outpatient facilities, but that doesn't address a patient's tobacco use. So if the tobacco use gets treated at all inpatient, how do we ensure that they are continually supported as once they leave that hospital? And so really right now I'm just going to focus on the inpatient setting, these three touch points: the admission process, which is focusing on screening for tobacco use and identifying patient interest in receiving treatment; the inpatient touch point, here we're focused on preventing nicotine withdrawal and also encouraging someone to pursue cessation if they feel like they might be ready to do that. And then connection to treatment. So discharge orders for NRT and tobacco quit lines, and then also connecting people to outpatient substance use treatment facilities and also outpatient treatment resources like quit lines. And so to really address the inpatient side, I've been funded by the Tobacco-Related Disease Research Program to conduct a study here at UC Davis where we are refining existing policy, which focuses on using clinical pharmacists to provide treatment for patients in hospital. That policy exists, but it is unrefined and not implemented. And so this project is really focusing on that process, engaging all the other stakeholders in the hospital, ensuring that the process can be as seamless and as efficient as possible, and then really using that as a piloting step to really think about how this might be applied in other systems as well. We are focused on patients with substance use disorder, even though these policy changes would affect the whole health system. And so we are currently in year one of this project, just started last summer. So year one is wrapping up in a few months. And right in this first year, we've really focused on the planning phase. So engaging stakeholders and preparing the implementation. And so the existing protocols for treatment involves nurses screening for smoking. Notice I said smoking and not tobacco use, which then auto-populates a pharmacist dashboard. This pharmacist dashboard then informs the pharmacist if a patient needs NRT, and then they sort of go from there. The planned refinements that we have really pursued are improving the screening fidelity, so ensuring that patients are correctly identified in terms of their tobacco use, ensuring accurate patient information. So a patient is interested in tobacco use, we want to be able to capture that, and then also improving the efficiency of this protocol. So avoiding, patients having to speak to providers multiple times about the same issues. And so, really, the current treatment model involves the nurse having a patient interaction, that information going into the EMR, and then the pharmacist receiving that information. And the way it works is the patient is screened for tobacco use. That information then populates the patient's social history tab in their EMR, in their Epic record. That information then gets auto-populated into the pharmacist dashboard. The pharmacist dashboard is something that pharmacists essentially use to review patient information and track their tasks. The pharmacist can interact with that dashboard to really focus in on patient, maybe high priority patients, and then they themselves have to interact with the patient to identify the patient's treatment interest. If the patient is interested, the pharmacist will then go ahead and order the medication. This process has a number of issues. First off, it only asks about smoking. It doesn't really ask about smokeless tobacco. And it also definitely doesn't address vaping and e-cigarettes. And vaping and e-cigarettes are becoming much more common, especially among a younger population. When you think of people with substance use disorder, a younger population, more likely to vape. So you're really missing potentially a lot of people that way. Um, there's also issues with the information that's being populated into the dashboard. This patient's social history tab has been reported to have a lot of problems. People complain about how it potentially gives wrong information, broken links to other sort of order sets. Um, the main issue we've been able to identify is that patients who are repeat patients at the hospital, they might have been current smokers in the past, and that, but at the current point in time, they are no longer considered current smokers. But for whatever reason, that information did not get collected at the present visit, and it sort of uses backlog information to fill in the gaps. And so this can create a situation where the pharmacist then sees, oh, this person needs NRT, goes to see the person's like, I don't smoke anymore. And so there's can be this disconnect that leads to a lot of sort of issues with pharmacist frustration, because not only are they having to identify a patient's interest, that patient may not even be a current smoker. So we're really focused on ensuring that this process becomes more refined, becomes more efficient. And so what we're planning on doing, we're working through the approvals right now with IT, is leveraging the acute care order set that the hospitalists use. This order set already has a checkbox for tobacco related treatment. And so we would essentially use this checkbox to sort of create a redundancy where patient interest in treatment, and not just their smoking status or tobacco use status, is made available to the pharmacist. So they can see that and not have to go to the patient then and have an interaction. It allows for less workload on the patient, on the pharmacist. It will be means therefore the patient might get their NRT more quickly, and therefore not have to go through withdrawal. Well, they might go through withdrawal, but they'll be spend less time in withdrawal, and have a better sort of experience in the hospital. Um, Sorry, there we go. And so currently we are, like I mentioned, we have been working with stakeholders. And so leadership in nursing, amongst the clinicians in the hospital, um, the clinical pharmacists clearly who are sort of there's the point people in our treatment protocols, and then also the substance use navigators and substance use intervention team. They have potentially a really important role to play that we are in the process of figuring out. Um, you know, their their interactions with patients are downstream of everything I showed you previously. Um, the patient might be in hospital for a fair number of days before they get contacted by someone with for substance use treatment, and so we would ideally be allowing patients to get their nicotine replacement therapy to avoid withdrawal much sooner than that. But they allow for a possibility to maybe evaluate the screening and patient identification process, and then allow for some greater data collection in that respect. We are sort of in the process of getting EMR changing approvals from leadership, and then further detailing how the implementation will actually proceed. And so that's sort of the inpatient side. So now I'm going to talk about the outpatient side. And when we think about everything that happens inpatient in terms of screening, identifying treatment interest levels, ensuring that patient doesn't go through nicotine withdrawal, and then counseling on tobacco cessation and connecting to treatment, all of that happens or is supposed to happen in the outpatient treatment setting as well. And that's because it's required by law. Assembly Bill 541 that was passed in 2021 and went into law in early 2022 states that any certified and or licensed substance use treatment facility in the state of California, so that is they're certified and or licensed by the Department of Healthcare Services, has to screen for tobacco use and has to either offer treatment or connect patients to treatment. And so the Substance Abuse and Mental Health Services Administration and SAMHSA, what they'll do is evaluate every state in the country for the practice of their behavioral health and mental health facilities. And so that includes tobacco-related treatments. And despite this law being in effect, California is ranked quite poorly, unfortunately. So in terms of screening, 40th out of 52 states and territories in the United States. In terms of offering cessation counseling, 31st out of 52. In terms of offering nicotine replacement therapy, 26th out of 52. And in terms of offering non-nicotine medication like Chantix, Varenicline, or bupropion, 28. So despite being one of the few states in the country that actually requires these facilities by law to offer treatment and screen, we are actually quite bad at it. So what we thought about was, why is that? Can we identify potentially why this law, is not quite, doesn't seem to quite be working as well as we hoped? And so this work, this was a short study that was conducted in last year through the Tobacco Cessation Policy Research Center, funded by the TRDRP, and the PI is Dr. Tong, who's also a member of my division and who's also a member of CHPR. And this work was focused on identifying, okay, is what the SAMHSA survey showing actually reflect what we're seeing in Northern California? And so we took a survey approach that we would engage the communities by working with local lead agencies, particularly health departments, county health departments, and then going straight to the facilities themselves and asking them about what their practice is. Like I said, this was basically a year-long study. We developed the survey early on, and then we focused in on two different counties, Sacramento County and Alameda County, both fairly similar demographically, Northern California, but they are very different in terms of how their health departments are organized to support their substance use treatment facilities, but also support them in terms of tobacco treatment and what is expected and required of these facilities at the local level in terms of offering tobacco treatment. So our core questions in the survey really focused on screening practice, treatment practice, whether the facility has a smoke-free policy, the respondents' attitude towards tobacco treatment overall, information on their understanding of AB 541 and whether it's required of their facility, and also in order to make this seem like less of a type of audit practice on the behalf of DHCS, we really emphasize the fact that we are interested in what their facilities' needs are in terms of improving tobacco treatment for their clients. And so under in terms of the organizations that are subject to AB 541 within the two counties, there's 30 in Sacramento, 22 in Alameda. We had about a third participate. So we we did not identify individuals, so we often would have different individuals from the same organization responding, um, and that complicated the analysis a little bit. But the reason we did that was we didn't want to spook people by thinking that, oh, we're going to be identifying, we're going to ask you for your name, thinking that, oh, they couldn't speak freely because this information might get back to their bosses or might get out to some sort of regulatory party and therefore create problems for themselves. And so we want to ensure maximal participation, and so we made it clear that this would be anonymous. And so the results in terms of treatment practice showed that in Sacramento County, we actually had more staff counseling for tobacco treatment. But everything in every other facet, Alameda had higher levels of medication assistance, referrals to the quit line, and referrals to outside providers. Um, and so they would take the path of like, hey, let's refer people outside for tobacco treatment. But in Sacramento County, the respondents showed that they were more interested in counseling in house relative to referring outside. Um, Out of all the responding facilities, almost all of them claimed to screen for tobacco use. And so that was not quite in line with what the SAMHSA survey told us. In terms of treatment needs, tobacco-free grounds was really an afterthought in Sacramento, and much more considered in Alameda. Um, but other than that, there was sort of a fair amount of similarity between the two in terms of identifying many different needs in the forms of quit kits, uh, educational materials. These are easy things to provide clients, so facilities are really interested in them. Medication, though, even though Alameda claims to offer a fair amount of medication treatment already, in terms of like over half, they were still interested in more. And so I think they kind of took the tact of, hey, why not just ask for it and see if we can get it? And so, sort of big picture, about a third of eligible organizations participated. In This was a bias sample, so we didn't randomly assign organizations to participate. So we're really getting people interested in responding, which is going to skew the results towards likely higher rates of reported screening and treatment than would be otherwise representative of the counties. But we did see a fair amount of similarities in terms of the high rates of screening and treatment among the respondents, overall positive attitudes towards tobacco cessation, and a fair amount of needs expressed for improving treatment for their clients. The differences were sort of in the fact that there was almost no interest in tobacco-free grounds in Sacramento, and that the medication and quit line referral rates were higher in Alameda than in Sacramento. So once the surveys were completed, our partners at the local lead agencies then engaged in follow-up. This was something we particularly tracked in Sacramento because this is not as established in Sacramento. So this was spearheaded by the County Tobacco Education Program, and they reached out to the 9 facilities that, through our survey, expressed needs for improved tobacco treatment. And unfortunately, there was very minimal success. So there was the initial outreach step, which is basically just an email. 7 out of the 9 responded to that email with some level of interest. And there was further follow-up, and that was where sort of things started to fall apart. Of those 7, only 2 continued to show interest in terms of further meetups, and then were actually engaged in an in-person meeting with the tobacco education program representative. So there's not exactly a clear sort of reason for why this seems to fall apart at this step, but from what we can tell, it really started all at the sort of program coordinator, grants manager, that level. So not at the local, not at the facility staff level, but above. And we think that essentially we got more responses, likely more responses from the staff expressing needs, and not from that administrative management level, who would then were like, oh, you're actually asking us to do something now. You know what? We're not. We'll happy to talk to you about maybe something vague, but then if you want to meet with us, no, no thanks. And so there was even one facility that was really hostile, was like, do not contact us again. We are really not interested. And that kind of took her aback. She's like, why are you so hostile? Your staff are actually telling us you need our help. And they just no interest. And a lot of that can be down to sort of traditional views, or it could be competing priorities, or it can be funding related. There's a lot of possible reasons for why the leadership at these facilities would not want to pursue further. And so, in closing, people with substance use disorder have a high burden of tobacco use and related disease. And this is true throughout the country and also true here in California. And the unfortunate reality is that those in recovery often do want to quit using tobacco, but they may not have the confidence or the necessary support to try, especially when they go into recovery, where at the treatment settings, that those outpatient settings, they're actually encouraged to smoke potentially, not not covertly, but if they see staff, recovery staff, providers at these facilities smoking outside, and oftentimes their only opportunity for any one-on-one contact is during these smoking break times, they'll smoke themselves just to get the opportunity to go and engage with the recovery staff. And so there is this unfortunate unintended um, sort of incentive to actually pick up smoking if you're not a smoker when you go into recovery. Um, and there is an absolute urgent need to address tobacco use and access to treatment in this population. The rates of tobacco related disease are very high, and this is already a population that has worse health relative to other groups. So it's really important to address this as soon as possible. The barriers to treatment exist largely at the organizational and institutional levels, and not at the client or sort of low-level provider levels. A lot of the staff members might be themselves smokers and have interest in quitting themselves, but just don't have the opportunity or the support to do so. So the potential exists. It's just navigating those really complex organizational and institutional barriers is a challenge and requires buy-in really at the local county level in terms of the public health departments who don't view tobacco as a behavioral health issue. And this is something that we're really trying to explore. How do we even tackle this? This is true in Sacramento County, and it's true in many other counties in the state. It's just traditionally tobacco has always been a public health issue, and mental health and behavioral health are separate. And those silos really function to create this issue where it's like no one wants, you know, the behavioral health views anything tobacco related as outside their purview. And at the same time, tobacco health doesn't have the opportunity to really go into those behavioral health settings to help address the problem. And so figuring out that Gordian knot, so to speak, is going to be what allows us to then really affect change. And that's all I have today. I'm happy to take questions. Um, these are a lot of our, I wish to thank a lot of our partners. So the Comprehensive Cancer Center, CHPR, obviously, Tobacco Cessation Policy Research Center, which is where we did all our outpatient work, and then all of our partners at the county level. Thank you.
Awesome. Thank you so much for a great talk. Sorry that I was walking and trying not to distract everybody with my bobbing head. Um, Thanks so much. If anybody has a question, please do raise your hand. I can call on you or put it into the chat, and I'm happy to read it out loud for Dr. Tseregounis. I have one to get us started. Um, really love how you're working in the implementation space across settings. It's really cool stuff. Eric, I was curious, have you, and I might have asked you this before in a different presentation, but have you thought about mapping your findings to like a theory or framework, like in terms of the different levels? It's a lot of social stuff, using tobacco to be interconnected interpersonally to others. There's other like policy, like have you thought about that or have you already been doing that? And I was just curious if that would be helpful for your work at all.
Yeah, thought about it a little bit. It's not really my area of training, so it's something that I would need to explore further. But our outpatient work has been largely sort of policy focused and not really implementation focused. We're trying to figure out, and they called it a rapid response project. It was really a project focused on, hey, here's some quick data to tell a policymaker so that they can decide if they want to pursue making any sort of, you know, policy related changes or propose anything. And so it's not really following your traditional like research approach. And the inpatient side, we're really early days on it. In terms of, we're definitely going to explore on the implementation side a formal framework in terms of how to actually proceed, and that's sort of to come in the next few months.
Yeah, and not even say that's needed. I was just curious. I mean, because it's hard when there's so many different drivers. I think that's more of why I was suggesting it. It's like, well, there's this evidence base, and then there's people's individual beliefs and needs, and then there's social stuff. You know what I mean? And like, how do you think about them collectively? It's really tricky because you have which makes your work very interesting, right? Because it's at the nidus of all of those things together, and even trying to tease them apart or bring them together in an approach, I think is really, you have a lot of opportunities in your work. So I think that part's really cool.
Yeah, no, I mean, especially on the outpatient side, I think it's really needed. Um, because inpatient, it's like, there's just more consensus in terms of of like how important it is for people to quit using tobacco. And I mean, we might take it for granted sort of in because we work at a health system, but outpatient, it doesn't really have the same, people don't feel the same way about it. And that might not be because they are antagonistic to it, but that might be because there's this sort of growing idea. There's already this idea of harm reduction in that space, and this idea of using vapes to sort of taper down smoking. It's actually, unfortunately, an idea that's taken root in a lot of sort of behavioral health area, amongst a lot of behavioral health practitioners. And that adds an extra layer of complexity. Nobody in the hospital is like, oh no, you need to start vaping to avoid nicotine withdrawal. Nobody's going to say that. And so you're not going to have those arguments in the same way. Fortunately, I'm not really engaged in that right now because I think that's incredibly tricky. And I think you could spend a whole career trying to figure that out. I'm not sure that I want to.
Well, we'll bring you along because there's so many cool, I mean, at least a little bit of like giving them tools to think about like what is the barrier, you know what I mean? And how can like because there's so many different barriers. It's different than just having a guide. Like you're saying in the inpatient, there's a guideline. Let's follow the guideline. Let's figure out, how to implement it. But there's so many other factors. So
Oh yeah, very
yeah.
complicated.
Yeah, which is what you're hitting on. So that resistance and sort of how to be aligned. Yeah, this is great. I don't want to dominate the whole conversation. What other questions are there? You can come off mute. Trying to pause for as long as possible. Can you talk, you mentioned at the end, but a second question while people are gathering their thoughts to see what other questions they have for you were, yeah, what I'm sure a big grant is brewing for you and sort of, yeah, can you talk about, because I was sort of alluding to that, but talk about, yeah, where else you want to take this in the future and sort of what other things you're thinking about. That would be great.
Yeah, right now we're really focused on the implementation side of this and identifying, the feasibility of it and the reach of it and the scalability of it. And that's kind of where we hope to have on greater clarity in the end of year two and in year three of the project. And then once we've identified, lessons learned, so to speak, taking that and then expanding it into a larger study, multi-site, hopefully, that would then look at like actual cessation outcomes. And so you can think of it as almost like a pilot, UC Davis sort of centered pilot, um, to identify if pharmacists can be sort of this like focal point in terms of offering tobacco treatment, because there's a lot of different approaches that you can take in terms of the different providers that could, um, really take on that responsibility. There's nursing, but they focus on the screening side of things, and they already have a ton of responsibilities. There's the hospitalist, but they also are addressing the immediate need, right, that the patient has in hospital. There's the substance use navigators, but they may not have necessarily the the training or the interest in providing tobacco related treatment. And so, in the process of thinking about what are the best approaches, we really focus in on pharmacists because medication is such a central role in terms of treating tobacco, especially avoiding withdrawal. In hospital, we really were thinking that is sort of um, a natural clinical, uh, focal point that we can rely on to not only offer quick short term tobacco treatment, but potentially like bridge to uh, um, other forms of treatment like a quit line referral, or maybe referral to like some sort of consultation or education program. Um, and those already exist, and they're already set up, but they're not really used very much. And so we're also hoping that, we can sort of educate as to like, oh yeah, you can use this, you might not have been aware of it, or you know you can sort of make your patients, make it known to them that they can contact the quit line, and if they're interested in quitting, and maybe increasing a little bit of awareness might also improve sort of usage rates there. So we're really focusing on like what has been happening before and what happens after,
Yeah.
and doing that direct comparison.
And then the spread part after the pilot. Yeah, that's great. Um, yeah, I have one more question in the chat from William Nelson. I can read it to you, and then I think we have time for one more after this even. Have you explored how different payment methods shape the likelihood of clinics engaging in tobacco cessation? And does capitation lead to more participation?
The payment aspect of it is really important, especially for the outpatient facilities, because funding is a real struggle for them, and it's always top of mind. We had When we first approached them, it was sort of through this. They have these like monthly meetings with the county health department here in Sacramento. They have these monthly meetings where they just update, and they allowed us to be a part of it, and actually shared the survey, and that's where we asked them, hey, you want to be a part of this? Please, here's the QR code, whatever. And a month later, we came back and tried to get those who hadn't attended the first time, but also gave them some feedback to sort of make them feel like, oh yeah, there's actually something that actionable that might come out of this. Um, and we once we talked about potential pharmacy collaborations, we're talking about like community pharmacies now that were interested in working with these facilities to offer NRT. Um, the question was immediately like, who's going to pay for it? And when they found out that Medicaid will cover it, Medi-Cal, since we're in California, would cover the cost. That like the ears perked up and people started to get really interested. So yeah, cost related costs. It also affects the willingness to treat tobacco. There's a fear that if you're the only, provider in town that doesn't let people smoke, that you're going to lose a lot of clients to all the other ones. And um, whether or not that's the case, that's what a lot of these organizations believe. And so it also leads to a fear of losing clients and therefore losing funding, is sort of driving a lot of the issues and the barriers that we're seeing, on that side. My understanding is that that sort of payment issue is also a lot of the reason why behavioral health won't necessarily take on tobacco, because like, we're not paid to do that. We're not compensated for that, and so it's not clear really to anybody what's covered, and so that's that therein is part of the problem. Unfortunately, don't have a lot of experience in looking at that side of it, so I'm more focused on the what's happening in terms of action and sort of patient encounters, and not really the billing side of things. And so, um, understanding that would definitely, um, not only understanding what should happen in theory, but understanding what happens in practice would be really important towards actually, affecting some level of change.
Yeah, it seems like maybe a potential secondary analysis too, if you wanted to look at the effectiveness and then segregate it by payer type just to see if there's any signal. I don't know if people aren't aware of it, if it's really would drive any of the outcomes, but I wonder if there's some subtle hints. And it's if they're all Medi-Cal, there's not enough variation, but it depends on the site. Um,
It's mostly
yeah,
Medi-Cal,
that's what I thought.
and
Okay, yeah.
and Medi-Cal in theory should cover a lot of it. But the billing process, especially with pharmacies, so like a pharmacy that says, "Oh yeah, Medi-Cal will pay us to provide you with NRT," it's like, well, they might bill for it, but not get compensated, for a very long time after that.
Yeah. That's
And
interesting. Yeah.
there's issues related to, so we're trying to work with a community pharmacy here in Sacramento to work with. This is another part. This isn't part of my project. It's another project, but to sort of explore increasing the pharmacy presence in this treatment space. And the current issues are related to billing. And the pharmacy is like, we're not going to do more because we're not getting paid. We're doing this all out of pocket and we're not getting paid for it. And we don't know if we'll ever get paid for it. And so it's like that's a huge hurdle to sort of manage as well.
Yeah, that's a fascinating angle. Um, I was just thinking at San Francisco General, where I used to be, we're seeing a lot more pharmacy data show up in Epic now that didn't used to be. Community pharmacy data show back up in. So I wonder if there's some new data sources in the future that you could tease it apart. Because it used to be so siloed, and now, not that that will solve all of your problems, because if they don't want to prescribe it because they're worried about it, then they won't do it. But if they do, and sort of whether or not the patient picks it up and all that stuff, there's a lot more. It used to be really hard to get that data, and it's getting better. To
Yeah, so much of tobacco related work also relies on individuals, what we call champions. And if you don't have that champion, it can make doing anything at the local level like really difficult.
yeah,
So talk about like Alameda County. Alameda County has a pharmacist there they're working with who doesn't care if they get compensated. They're like, oh, I'll get
passionate.
paid
Yeah,
eventually. I'm not
yeah.
worried about it. And so it's almost like it's impossible to predict, at least at the local level, unless you have policy really driving something. Unfortunately, unless you are threatening that you will withhold something, oftentimes it's not so effective. And the issue with AB 541, so AB 541 exists, but AB 541 doesn't articulate what will happen if you don't comply with it. And it doesn't, so there, it's not like, oh, we're going to take your certification away. It never says that. Um, and from what I understand, there's like zero enforcement of it. So, there's not a whole lot of incentive, you know, to you to be um, very vigilant in terms of complying with the law. You might do it on sort of the bare minimum, just so you fly under the radar, because there isn't really the law itself hasn't been is full of generalities and vagueness, and there's a reason for that. Obviously, there's always a give or take at the policy level, but it does sort of show that the law itself does not go far enough, and that it needs to be rethought, or maybe something needs to be added to it. But from what we are seeing, the levels, especially related to the rest of the country, of tobacco treatment at our facilities is really low, and it needs to improve.
Yeah. That leads into my final question. Well, the overall policy environment. Do you expect a lot of change given the current federal funding climate and sort of, I know there's CDC and the Office of Smoking and Health, and there's some other federal stuff happening. Is that impact trickling down at the state level here in California, or any other things that you're seeing about what
Yeah,
changes might be coming?
unfortunately, yes. I don't know about. I haven't heard anything about like substance use related to, like specifically anything tobacco and substance use related, but I do know that tobacco related programs are being cut all over the country, and that's because the CDC basically closed. I don't recall the name of the agency, but or the of the group, but they basically stopped all funding. So this doesn't affect California as much because California has a lot of state tobacco tax funding, many of the tobacco cessation programs here, but like in other states that rely completely on that funding, it's all gone. A lot of those groups, like the people no longer actually have jobs there. And so I think one group that's California related that was really affected was the Asian Quit Line, that basically had to stop taking calls, and if someone called them, they would tell them, sorry, we can't talk to you. You need to go to this website to get information. And that's been happening as soon as this week. And a lot of the so our cessation policy research center, a lot of the conversations lately have been like, how do we respond? Because we have a policy bent, so it's like, how do we actually reverse some of this? And those conversations are happening, and it's not so much for our state, it's more for the rest of the country that doesn't necessarily have the same state level support that California does.
Yeah, it's a little negative note, but I was trying to make it seems like California has some positives too. So trying to take that, and moving forward, and just the importance of your work, right? Given how central this is, how important, how co-occurring is with people with substance use conditions, and just like we can't not focus on this despite all these other changes around us. So just really appreciate all of your attention and your focus on such an important topic. Eric, I really appreciate you being here and giving our seminar today. You put your email here for everyone so they can reach out to you if they have other questions.
Excellent.
But yeah, we're really excited to have you in the center and just really appreciate all of your work. Thank you for coming today.
Thank you. Thank you for having me. And if anybody wants to be more involved in our UC Davis project, please don't hesitate to contact me. I'm always really happy to talk to anyone with an interest in improving, the tobacco treatment offerings here. So thanks again, Dr. Lyles, for the opportunity to share my work. And, I look forward to being able to do so again in the future.
Amazing. Have a great day, everyone. Thanks again.
Bye-bye.